So last time I talked to you in this room, we talked about STEMIs and EKG review and trying to give some little pearls about, what you can read, what you can't read. And I think we talked about left bundle a little bit and pacers and kind of distributions, left heart, right heart, I'm sorry, left coronary, right coronary, et cetera. And you guys, of course, aced it and didn't seem like I was giving you much new information. Uh, when I was thinking about what to talk about this time, I think one thing has changed a little bit at St. Mark's, and I'm happy to get feedback on it and see what you guys' impression is. But maybe in the past 5 to 10 years, maybe you guys have felt like you'd kind of send an EKG and say, we got a STEMI, and hopefully it would seem that way when you got there. And sometimes the patient in the daytime anyway would just, maybe a few times you've had the experience where they didn't even stop and they just kept rolling up to the cath lab and maybe even went there and watched what happened. I don't know if it's your impression that maybe that's not happened as much in the past year, but I feel like maybe it hasn't. We review these and there's what people remember and what actually happened, and sometimes what people remember when they're grumpy and it's 2 in the morning is that one time where somebody said it was a STEMI and then it wasn't, and then that turns into every time, and they think, well, every time they call it's not a STEMI. Like, well, no. So we tracked it, and just like we anticipated, at least 80% of the time when it was activated from the field, that's what it was. It was the right call. We know we're not going to be perfect, and that's not the expectation. It's just, what else can we do to try to make sure that we're getting better? And so that's what I wanted to try to focus on today, because there's so much crap out there that can fool us, from the patient to their chronic diseases to things that look and talk and act just like a STEMI that aren't. And you're not going to get all of them, but maybe if we delve into them a little bit more, we can at least think about them. And I feel like when you guys call me and say, I've got this guy, he's got this risk factor or whatever, he's got this story, and he's got this EKG, and I think that's what's going on, then I feel really good about saying, yep, you're probably right. Let's get things going. So this is just to hone that in a little bit. So what I want to talk about today is, which button do I hit? Just hit the
back on. Here should work for you now.
With this. Oh yeah, look at that. Mimics. So let me move that chair a little bit. So that's kind of what I want to focus on today, is things that look like STEMIs that aren't, or EKGs that look like STEMIs that aren't. And just to back up, we're going to kind of talk initially about kind of how far things have come, because a lot of you guys are young and don't remember things in the dark ages, kind of where we are now, and then how we can continue to get better. And then we'll talk about the things that are mimics, kind of categorize them a little bit, give some examples and give some strategies to kind of help with the limited tools you might have in the pre-hospital setting, kind of point people in the right direction right off the bat, when to stand up and when to stand down, We'll talk about the definition, how things have evolved, what that effect is on mortality. I think importantly, what EMS activation of STEMIs in the field, what the effects on mortality are there. I don't know if you guys have ever seen any data about that or been told like this is how much it affects. So I dug some stuff up on that just to kind of tell you. This is all hopefully old news to you guys. The definition, ST segment elevation in 2 contiguous leads, more than 1 box basically. Yeah, except for in B2 and B3 where you want like 2 boxes. And then there's really specific stuff, men, women, old, young. But the bottom line is if you got a box, it's elevated, and it's in a couple leads that are next to each other, and they've got a good story, you've got your definition, right? And then there's left bundle definition, which gets really complicated, and we'll come back to that later in the lecture. But the bottom line is that the ST segments go up opposite the QRS, and we talked about that last time I lectured you guys. And so if the ST goes in the same direction as the QRS, that ain't right. Or if it goes up really elevated and you're just like, man, that's a boat ton of elevation, that also ain't right. And that's basically what the little bullet points state there. We'll go over that in a little bit more detail. So this is a little slide that hopefully kind of shows you what you need to see, which is that people are living through STEMIs a lot more than they used to. Right, when I was in grade school, 13% of people died despite whatever you could do for them in the hospital, which is mostly just staring at them. And then the GISSI-1, that's the name of a study that they did where they studied this drug called streptokinase, which is like one of the first clot busters, SK. And so when they gave that drug and they're experimenting with that in the 80s, they said, oh, look at this, people are living a little bit more. And this is all coming around the time that they realized that STEMIs and Widowmaker heart attacks and all those things were caused by plaques that got unstable, ruptured, and then platelets kind of clotted on top of that ruptured plaque. And that's, believe it or not, that we didn't always know that. And so then when they did, they're like, all right, well, what can we do to get this clot from forming? Well, let's use a clot buster. And that really started accelerating the care of heart attack patients. Then the third blocks over, you notice that they had aspirin. They're like, well, that makes a difference. Maybe, what does aspirin do? It blocks platelets. Well, platelets must have a lot to do with it. That's called the platelet aggregation on the unstable plaque. And then the Gusto trial is a big famous one. That's when TPA came out. And then they realized you could give TPA, but the earlier you gave it, the better, kind of like we're talking about with stroke these days. In the heart attack studies, it went out like 12 hours. But then there was a risk of bleeding. And so then the ASCENT trials, when we started doing angioplasties and stents and things like that. And so you see the mortality dropping and dropping and dropping. And basically, we've got it kind of whittled down to a pretty tiny number. But you got to remember, these are all done in study settings where, there's strict inclusion, strict exclusion, latest state-of-the-art academic medical teams where there's everybody always available all times of the day and night. There's residents swarming around. So in the community, it's not always going to be that good, and it isn't. But it still follows this trend. So still this year, according to the American Heart Association, we have about 750,000 STEMIs a year, despite cardiac scans and everybody knowing what a heart attack is and their mother. When you treat it, you're basically whittling it down to 6% people dying. And if you don't do anything, up to a quarter of people will die. So it still matters, I mean, it still is not something you just want to ignore or can afford to miss. It's still an important disease with a lot of burden, a lot of mortality. So what happens if you start activating pre-hospital? This is something that when I graduated from medical school and even in residency, and even for several years out of residency, I would never even have thought of. I never would have thought that you would have somebody go out, do an EKG out in the field, put it over the interweb, and then we would like do a bunch of stuff just based on that. And then after I've been at St. Mark's for about maybe 5 years, I remember reading this paper, and I think it was done in like Taiwan or Korea or something like that. And it's like what? They do an EKG on people and they just bring them right into the cath lab? Like, is that a thing? And then I think it was about 2010 we started doing that here, somewhere around there. And a lot of the data that I looked at was about that time. And mostly the early studies are just looking on door to balloon. And obviously, if you activate earlier, the door to balloon goes down, right? And so that's kind of a no-brainer. But the studies were saying, let's do that and prove that it's a safe and reasonable thing to do. So the studies initially were doing that. And they did prove that it was a safe and reasonable thing to do, that the EMS were, when they got used to it, they could get good at it and they could be right most of the time. And that was worth the juice there was worth the squeeze. I found a couple studies, not a lot, but just a couple studies recently, one done in Australia, one done in Japan, that looked at like what we actually care about, like how does this affect patients down the road? Not necessarily did they get their balloon faster, but did they live? Did it make a difference? And most of those studies tend to be done in non-US centers because we don't have national health care, so we don't have giant databases we can look at. But a lot of these European and other kind of advanced economy countries do have that. So Australia looked at it, and there's their 30-day mortality and 1-year mortality numbers. You can see that's a huge difference. 1.6 mortality if they were EMS STEMIs, 6.6 if they weren't. Like, that's a big, big difference. And then at a year, it still bears out. And these aren't healthy people. So if you're having a heart attack, your risk of dying is just going to be higher anyway. And then in Japan, they put it in this kind of number needed to treat, right? So for every 1,000 runs you do, you're going to save 26 lives. For every 100 runs you do on a STEMI patient, you're going to save a couple people. So that means if you guys yourselves are doing, 50 STEMIs in your career, you've definitely saved a life. I mean, that's kind of a big deal. And if you think out the year, the long-term mortality, you're saving a couple lives, each crew. because I'm guessing that you guys are probably doing 50 STEMI runs in your career, I would guess. So that, to me, you know, don't lose heart. For every homeless dirtbag that's intoxicated, there's a life saved somewhere in there. So, all right. Did I say that out loud?
Okay,
Probably. Okay, I didn't say names, so we're okay. There's a downside, right? I mean, if we activate, we're waking people up. Most hours are after hours. I always have to tell the hospital administrators that. Like 9 to 5 is not very long in the day. You guys know that. And Monday through Friday is not all that many days of the week. So a lot of times when we're doing this, the obvious majority of the time, people are supposed to be at home, being with their families, whatever. And a lot of those same people are here during the daytime, and they're supposed to be awake and chipper and doing things for patients that are signing up to get procedures done to them. And in Salt Lake Valley, I think a kind of a unique problem is that our housing is so ridiculous that most of the cath lab staff are living out of town, Bountiful, Harriman, whatever, and it takes them quite a while to get here. I mean, it usually will take us 30 minutes after hours to get everybody here. Daytime, no big deal, everybody's already here. So that's the upshot, right? It's important to get it right because you can't beat on the resource to the point that it's not effective for the people that we know have problems during the daytime that are, that we know they've got a blockage, they're coming in for their elective PCI, and we want to have a good outcome for them because they're a known quantity and they don't expect some half awake person to take care of them. But it's also easy to get fooled, and that's what we're going to get into today. So we're going to talk about the mimics of a STEMI, and the top is, the guy, right? That's the clinical picture. Somebody's having chest pain. So that's like why they're calling you. And then there's the bottom, which is like the EKG stuff, right? Because sometimes you'll have an EKG and it'll scream STEMI, but then, that may not be the clinical picture. And sometimes you can have both where it sounds like the clinical picture and the EKG looks right, but then it's still not. So I kind of wanted to differentiate it between things that can sound like a heart attack, but they're totally something else, and things that look like a heart attack, but they're something else, if that makes sense. So the clinical stuff, there's dangerous stuff to me, and then there's non-dangerous stuff, right? The dangerous stuff, the biggest probably, right, is the dissection. Like that's a disaster, and we need to know about it. And, it's a surgical disease sometimes, and it's extremely life-threatening. PEs, we have a tremendous number of walk-in PEs, and I would say it even outpaces the ambulance PEs. But it's still a pretty dangerous disease and needs this very specific treatment. Esophageal rupture, like those people look super sick. They're often coming in by ambulance, and they can look just like they're having a heart attack. And that's one that if you go down the wrong path and you let it go too long, they get septic and have a really bad outcome. I don't know how familiar you guys are with the Takotsubo or the broken heart, which I think I misspelled actually. But that's the broken heart syndrome, can put people into heart failure and even kill them, and can be a different disease than a STEMI for sure, but look exactly the same. The number of people we've sent to the cardiologist to treat pancreatitis is not that frequent, but embarrassing, very embarrassing when it happens. And then I personally tried to kill one of our psychiatrists in residency with a hot gallbladder. It's amazing how much these things can look like they're having a STEMI. And stuff like pneumothorax, I mean, that's stuff that we're going to hopefully get figured out before they go anywhere. But then there's the benign stuff. By far, in my experience, the most common is reflux esophageal spasm. I mean, it can look and feel and act just like a STEMI. And depending upon what people's diseases are in the background, they can look like they're having a STEMI. So we can get fooled by that pretty well. Things like pleurisy. I don't have pericarditis out there for some reason, but that's another one. Dissection. This is a lady I had last month. She came in with chest pain. It was sudden in onset. It was pleuritic. It hurt when she breathed, which when I saw her images, it made sense. And she had it radiating into her back. She died. She knew she had an aortic aneurysm in her thorax and didn't want it repaired, and because she was like 80, and it's not a good way to die. It turns out all that blood there smashed. I don't know if you can see. right here, but that's her right main stem, and you can't even see her left main stem because all this blood is just smashing on it. And she started gurgling, and it ended up being kind of ugly, but a bunch of morphine and it fixed it. But and then this is the contrast in her aorta, and this is clot in her aorta, and this is contrast leaking around her aorta, and this is blood just all surrounding the heart. And
fix that?
I know I tried. I've only seen this twice in front of me. Once the patient just came in, looked at us, and just keeled over and died. And the trauma surgeon happened to be there, and we cracked her chest open, and all this blood came out. And I'm like, oh, this lady, she was still alive. She lived for a good couple hours. You try to catch them before that, and I don't know, have you guys ever get follow up on the dissection cases? It's not a common thing. Every once in a while. I always wondered so if they hit this part of the aorta, the ascending aorta here, that's called a Stanford A, and if they just hit the lower part of the aorta, this part here, that's called a Stanford B. These we just watch, but the ones that come out of the aorta, the top part, are the kinds that you fix, because what you can do, there's like a little hole, and you can see it here on this lady's image. The surgeon can go in and tack that hole shut, and then all the blood kind of fills up the normal hole and kind of smushes down that clot that's around there. And it's like when you have one of those little advertising balloon things, that they do like the car wash and stuff, where they're blowing air through it. So you can imagine that the blood going through the right tube and just filling that tube up and making it look more like a normal blood vessel again. And people can do okay. It's shocking. I've had some cases where I'm like, there's no way this person's going to live, and then they do okay. So that's like a real important one to figure out. And the type of pain, most of these I put like all in order of importance to me. It's sudden. A heart attack can be sudden, but this is definitely very sudden. It doesn't build up. It's just bam, all of a sudden I had this terrible pain. It's often ripping or tearing, and it almost always radiates somewhere weird, like into their back, between their shoulder blades, down to their belly, something of that nature. So if you've got that quality of pain, even if they have a STEMI, it's worth collecting that historical data and passing that on to the charge nurse or the doc or whoever's taking the call. And then blood pressure discrepancy. It's something that my nurses do on every chest pain, is check a blood pressure like on both sides. But I honestly don't know, especially the new young ones. Like, do they really know why they're doing it? Do they know what to do with the data? And sometimes they'll come to me like, oh, it's 160 in one arm and 180 on the other. And I don't know what to do with that. But if it's like 80 on one arm and it's like 200 on the other, that's probably something to pass on. That's probably important. And you can imagine what happens if you anticoagulate this person, right? That's not always the best thing. And then a lot of times they'll have chest pain plus, so stroke symptoms, abdominal symptoms, extremity symptoms. As this aorta rips down, the pain will often move with it, and the pain will be chest to back to belly to leg, or they'll clot off a vessel to their brain and have like a stroke or something like that. And so when you're starting to see like weird symptoms and the patient looks like they are dying, this is the disease to think about. And they should look like they're dying. It's not good. Questions? PE, this is something we see pretty regularly, it seems like anymore. This is like a little clot sitting in the pulmonary artery here. It'll come in through the vena cava, right atrium, right ventricle, and then hit this little bifurcation, and usually it'll lay across there or shatter into a bunch of pieces. And so just like the previous one, it's a sudden pain, so that's kind of how you usually will get it. And they'll either have a pain, or they'll feel dizzy, or they'll feel short of breath, or all of the above. If they do have pain, it's often worse when they take a deep breath, pleuritic. And then, of course, there's almost always a component of shortness of breath with it. So sometimes that's the only complaint. And you might think, oh, look, they're having a heart attack or something. But the main reason that you're going to want to put this on your radar is with the vital signs. Almost all these people are going to be at least a little tachycardic. Some of them will have hypoxia, but most of them will be like just in the low 90s. And then risk factors, right? They're coming from a rehab center with a cast on both legs and they have sudden chest pain. You got to put the PE on your differential, right? They've got cancer and they're a chemo patient and they got sudden chest pain. You got to put that on the list. And hopefully that'll kind of help keep you out of trouble from that one. They're almost always tachycardia if it's a significant thing. Almost. And STEMIs usually are not, in my experience. They're often normal or sometimes bradycardic even. So something to think about. Be the rare PE that gets bradycardic. This is not one you often think about. The reason this can fool you is because you will have a terrible horrible, terrible chest pain when you rupture your esophagus. And a lot of times you rupture it because you're vomiting. So you might get a call that someone has chest pain and that's why you show up, and then they're vomiting everywhere and they're uncomfortable and they can't talk to you because, when these patients are in distress, that you don't, it's hard to get a good history. It really is. Um, so hopefully somebody else can tell you what happened, what the order of events was. But if a 40-year-old guy is went on a drinking bender and then started vomiting and then has all this chest pain, then it might be a total nothing burger. But if they look super sick, this is one you put on your list. And their EKG, as you can imagine, from all this air from a ruptured esophagus, that's what all the black stuff is. It's all air, doesn't belong there. And now it's surrounding the heart, so that's going to make for some funny looking EKGs. It's not going to be an easy one to interpret and get to the bottom of sometimes. And it's not that common. It's like a dissection probably as far as incidence. They've got to have a mechanism though. You don't just have this happen out of the blue, right? They've got to either be vomiting something fierce, just had endoscopy, swallowed a chicken bone. One that is becoming increasingly common that I guess I just don't remember seeing that much of when I was younger is all these cardiac procedures. We're doing all these ablations on AFib, SVT, A-flutter. We're putting in all these pacemakers. It used to be you just got a pacemaker if you had bradycardia. Now they're doing it for heart failure patients. Now we got shock boxes. If you got a low EF heart failure, you guys are getting the patients through their STEMI by bringing them in the hospital quickly. And now they're living. So they end up with heart failure, and then they end up with these procedures. And so what will happen is these pacemaker probes will often sit there in the atrium, and if they kind of screw them into the muscle, right, to generate the electrical signal. And if something goes wrong, or it gets a little too deep, or it erodes away, it can create, or it gets infected for that matter, it can create this little fistula tract between the esophagus and the heart and the pericardium, and you could get this leak, and these people will get this weird chest pain. And again, their EKG can look funny because they've either had a procedure, they're a cardiac patient, or there's just a bunch of inflammation around their heart from all this stuff going on, and it can be kind of confusing. So just something to think about. If they've got a fever and they seem like they're having a STEMI, you're like, that's weird. Why would they have a fever? And that might be something that's going on. Or if they're just retching. Pretty uncommon, but very, very serious. Pancreatitis. We talked about this one earlier. So you see Dr. Weissel in the ER, just ask him if he's going to get a lipase, which is the test for this, on any of his chest pain patients, and he'll just kind of smile and turn red. We've all had our experience with the cardiologist where we messed up, and this is a good one to remember. It'll often give you pain up in your chest. Always, not always, but very often give you pain in your back. Usually an alcoholic. Usually there's some GI stuff going on with it. They want to throw up, they can't eat, something of that nature that'll clue you in. And again, unfortunately, they can also have cardiac history because, the unhealthy living and have abnormal EKGs. So these can often fool us. It's mostly the risk factors, and then anything abdominal, you'll want to think of something like this. And it's pretty hard to have this disease and not have tenderness in your belly. All you got to do is poke on the belly once or twice, and if it's obviously causing pain, then maybe it's not the heart this time. This is a big swollen pancreas. It shouldn't look like this at all. It should look like a piece of chewed up chewing gum, and this just looks like a big blob. And you see this is fluid. This will create a bunch of fluid that gets up under the diaphragm and creates all this pain that gets referred up to the chest. And that's how sometimes it'll give me pleural effusions, and those can give you chest pain. So there's a lot of ways it can give you chest pain. Let's see, cholecystitis. Yeah, I'll never forget. I'm so embarrassed. I was a third-year resident. Psychiatrist came down, sudden onset, like lower right chest pain. His EKG looked just like this. This is one I pulled up off the internet, but it's bradycardia. It's kind of ST changes. It's got some ectopy. You're just like, what is going on? The guy's sweating. He's bradycardic. His blood pressure's kind of low. And I'm like, crap, he must be having like an inferior lateral. He's got these T-wave inversions. He's got this lateral stuff. We better get him the cath lab. And he's a professor, so we're like, got to give him the red carpet treatment, got to wake the cardiologist up, get things going. And they bring him back from the cath lab, and everything is normal, and he's still in pain. And it strikes me that maybe it's his abdomen. Anyway, after his cath and his blood thinners cleared out, they got him in the operating room, and he did fine. But I even gave him nitro. Boy, that was a disaster. Dropped his blood pressure, made him look even worse. Problem is it can give you bad vagal events when you get an abdominal problem, and the bad vagal events can give you really weird EKG abnormalities sometimes. And everybody knows that the right coronary heart attack can give you bradycardia, right? So, and often the right coronary heart attack will give you upper abdominal pain. So it's just easy to get fooled sometimes on these, and I probably just should have done a better abdominal exam on them, and could have avoided that. So something that you may not think to do when you're doing a chest pain workup is maybe poke on their upper belly and when you're putting the leads on, and just make sure something obvious isn't going on in their upper belly. Let's see here. So that's the clinical mimics, the things that may have symptoms that sound like a heart attack. Let's talk about the EKG mimics, the things that look like they're having the big one. Everybody's familiar with pretty much all these things, right? Left bundle, early repole, pericarditis, LVH, Takotsubo. And there can be more, pacers and things like that, but these are the biggies. I think left bundle is extremely common. And remember, it used to be kind of an activation event. New left bundle with chest pain. It's my least favorite because so many people out there have left bundle. It's not something that I get excited about, activating the cath lab for. But there are some things, and we reviewed this last time I talked to you guys. This ST segment should be going the opposite direction of that QRS. The big pointy thing points down, the ST should go up. Kind of like this one. That's how it should look, right? So big pointy thing goes down, ST goes up. Pretty easy. But out here you can see it's not what's going on. It's going in the same direction as the QRS, and that is not right. And that's when you see that, you can say that's probably a STEMI. At least send the EKG and say I've got at least an ischemic guy. And I see that EKG and I get very excited, which is hard. It's so hard to do when you got a left bundle or a pacer, but that's your bread and butter. The other criteria was if the ST elevation is 5 millimeters or more. And so that would be like if this guy was more than a whole big box. I don't like that one as much because voltages can be different, and we'll get into that in a second. But I guess if it looks like, holy cow, it's still a giant STEMI, it's really, really ugly looking. It's certainly worth getting excited about. Excuse me. History is key, though. All right, why are you doing the EKG? And I see sometimes, EMS, doctors, nurses, all of us, we get this EKG, it looks really abnormal, and we start saying, oh, it must be a heart attack, and we kind of forget the reason the patient was calling to begin with. Was it belly pain? Was it shortness of breath? Was it I sprained my ankle? What was it? Thanks, man. Because sometimes we can kind of get ourselves into the weeds when we get a real abnormal looking EKG. And if there's any question, just go back to the history. What am I on this call for? Is it fever? Is it decreased mental status? Is it something that probably isn't a STEMI? And then we can kind of take a breather and step back. But certainly, man, a 64-year-old guy with severe chest pain, sweating with an EKG like that, you want to get excited about, and go ahead and call it. Early repole, man, this is still kind of a mystery to me sometimes. I'm not going to lie. It's one of my least favorite because it can look so bad sometimes. So the J point, let's try to clarify the mystery, right? That's a J, right? That looks like a J. And so that's the point which the J begins, right? And if the J point in isolation, which is just this one point, is elevated, but the rest of it looks like a J, in theory, that can be a normal variant. Whereas you see here, there is no J point because it doesn't make a J. It goes into like an upside down looking thing, like a backwards J or whatever. That is more the ST morphology you see with a STEMI. And so that's the more concerning one. That's what makes the tombstones, right? Now, you don't want to, this is one where it's nice to know about, but you don't want to die on this hill. I mean, if this J point is still looking like a J point, but it's way up here and someone's got a good story, I think we got to do everything we need to do and rule everything out. I don't think we say, well, it's probably J point. But a 20-year-old who's super skinny and is athletic might have a big, huge voltage and a little J point elevation. And if you stumble across an EKG for whatever reason and your suspicion is low, maybe give that information to the charge nurse or doc that you're giving a report to. And that might be helpful information, kind of keep us all out of trouble.
Hey guys.
See you guys, thanks. Pericarditis, It's something we saw a lot of during COVID. This gives you ST elevation, but it just mostly gives it to you everywhere so that you'll have it in so many leads that it doesn't even make any sense. You'd have to have an infarction all over the place. And so that's your big clue, is that you've got a terrible looking EKG and the ST segment elevation is everywhere. Often these are younger patients. The pain is kind of usually weird. It's not like typical STEMI pain. It's pleuritic. Maybe it feels better if they sit forward or versus if they lay back. Often they had a flu or COVID or some sort of bug. So this is one where the EKG definitely is abnormal, but you put it together with the whole picture, and they will often have this fluid layering around the heart that helps drive some of these abnormal changes here. Not super common. We saw quite a bit of it during COVID. And I guess I would say maybe even with the vaccines, maybe. Hard to say. Everything. I know you could blame it all on the vaccine, right? My butt itched for a week. I don't know. LVH. All right, this is another super common one, just like left bundle. And it's really hard to just see the EKG and be like, oh, I guess that's normal, right? Because it's not normal, but it's not necessarily a STEMI, and it might be the way it is all the time. They just walk around with this. But the big point here is when you see these gigantic QRSs, then that may be a mimic. And if there are symptoms that are all atypical, like I just have a funny bunny feeling, I got a funny feeling in my chest, or I just feel like something's not right, and you get this EKG because that's what you should do, and you see this, that's a good one to pass on to whoever you're giving a report to and say, hey, there's ST elevation, but it sure looks like it could be, LVH. This person's got chronic hypertension. They don't take their blood pressure medications. Maybe if we ever get to the point where we can get names and date of birth on a regular basis, which I know has got its obstacles, we could probably dig up an old EKG and see immediately that this is chronic. But there are some rules, just like everything. If this big giant spike from up here to down here is, say, 50, let's just say it's 100 millimeters for ease of math, and from here to here is 25 millimeters, so 25% of it, that's one of those rules where it's probably still going to be a STEMI. And that'll look pretty obvious to you guys. You guys have seen enough EKGs that you're like, well, that's a big voltage, but that ST is way up here. That still isn't right. And that's one where you can go ahead and read through it. These leads, V1 through V1 through V3, remember this is the part where you're closest to the LV. It's sitting right up against the chest wall. And V2 and V3 in particular. And that's why in the definition of STEMI, that one box of elevation, they say except for V2, V3, because that's where you're going to see that kind of early repole ST abnormalities just because of proximity to the heart and the forces that go through it. So if there's no ST elevation here and there's ST elevation over here, then that you got to be careful calling that hypertrophy. That could probably be something else. Most people get hypertrophy have a lot of big changes in these V1 through V3 leads. So if you're not seeing it there and you're seeing it elsewhere, then that's probably not hypertrophy, and you should be careful of that. Likewise, with this big voltage coming through these early V1 through V3 leads, the T wave should be up. And if it's down the other way, then that's also really weird. Something's not right about that, and I would probably say it's something besides hypertrophy. That's kind of a tough topic. Questions on that? All right, moving through. Broken heart syndrome. I swear we see this at St. Mark's like once a month. I didn't even know what this was when I was in med school. I didn't think it was a thing, but it's so weird. Stress cardiomyopathy. Maybe the world's going to be a more stressful place. Stress cardiomyopathy. Chronic cortisol exposures can eventually cause the myocardial wall to thin out, get weak. And when you look at them with an echo, this is the LV. And the idea, I guess the takatsubo is like this Japanese word for an octopus trap. And so I guess it's supposed to look like the pot that they trap the octopus in. And so, yeah, it's all big and dilated. Yeah, sad octopus. Or grimace maybe, or I don't know, or the Pac-Man ghost. There's a lot of things it looks like. Had some of this at sushi, a little taco. Yeah, taco. So this is the EKG that I picked out to demonstrate it, just because this is probably what I feel like I see the most. You see on V2, you got this little Q wave, a little ST elevation, and you're like, man, that's not right. And it's got ST elevation, but it's not that scary. And the rate's kind of fast. And the patient's story is kind of like, well, I've just not been feeling well for a couple weeks. And then I got real short of breath today. And so you're like, what do I do with this? Well, what you do with it, honestly, is you activate the cath lab and you go look at it. And unless it's just like this EKG, this EKG, you just have the one lead, really. Maybe these ones you could call, but they're not contiguous. So if the EKG just has one or two leads, or they're one over here and one over here is up, you might work with the cardiologist, say, we'll just get an echo now, and if it looks like it's a slam dunk broken heart syndrome, we'll just stop. And I feel like we got enough experience with this now at St. Mark's. We do that from time to time. I did it just the other night, in fact, about 2 weeks ago with hacking.
What do you do since
You treat it like heart failure, and it'll often resolve on its own. And these people, a lot of them will have a totally full recovery. Oh, shut up. Oh, I just bit for that, didn't I? Well, let me tell you, son.
these offers after?
There's so many songs. All you got to do, get on Spotify. It'll tell you how to fix a broken heart. I think it involves whiskey. But yeah, we'll treat these people like heart failure. I'm amazed at how well they recover. Let's see. So let's review all this crap one more time. So hopefully I showed you that, we've evolved a lot just in the past 50 years. We've gone from just staring at people to giving them medications to like pretty advanced pre-hospital care to, having you guys wheel people up occasionally right to get their groin stuck. In fact, we don't even stick groins anymore, we stick wrist. The cath lab has definitely become a central focus of STEMI care. It seems to be the best thing to do. There doesn't seem to be any doubt about that. As long as it's not some super old person with a bunch of medical problems who's demented and is DNR, then that seems like the right thing to do. And then the activation not only makes a difference from the field on time, but on outcome, right? The patients are doing better when you guys do this. And I feel like the cost of waking people up in the middle of the night can easily be mitigated as you guys get more experience and we get more experience on both, getting the history, passing that on, getting the EKGs and passing that on, and the way we communicate to one another before you get here. But we're never going to be 100%. These mimics I'm here to kind of show you what they look like and put them in your mind, but we're never going to always be 100% of the time right. But hopefully with just some more, knowledge and expertise, we can improve. And always remember at the end of the day, why did somebody call 911 before I get too excited about this EKG? Why am I here to begin with? Is it like a broken toe or something? And then what does the patient look like? Are they texting on their phone, or they look like they're about to die? And I think, man, as long as we come back to that, we're usually going to make the right call. Usually. That's my little rapid fire presentation to you guys. Any questions? Other thoughts?
How quick do you get our transmitted EKG in your hands?
It will be usually within seconds to minutes. So if you guys call and you say we're transmitting an EKG, sometimes the EKG comes before, if the machines are working right.
Yeah, we try to send it so it can be hopefully in your hands while we make that
Yeah.
policy.
Because the little computer makes a little ambulance noise. Woo! And because we have so much coverage at St. Mark's, there's, at peak hours, there's like 4 people sitting around.
And actually, right now, we've kind of helped mitigate getting to the cardiologist real quick by.
Oh, yeah.
It's when your 12 lead comes in, it automatically goes to a certain email, and that's distributed out to all the cardiologists and ED leadership right then, so they get it at the exact same time. So we had one of the cardiologists say, "Now I get everything." I said, "But that's okay because I'm a nerd and I like to see them all." So.
Yep. And so as the systems improve, I think that honestly will be less of a problem. And I think the cardiologists at that point are wondering in their mind, because they want to know everything, what does the patient look like? Are they bringing me some demented person that, doesn't want anything done, and I'm going to, come charging in only to find out that, I shouldn't be doing anything? Or are they bringing me somebody on 5 blood thinners 4 ways from Sunday that's going to bleed everywhere? Or they're bringing me some guy that has like, belly pain and has a stomach flu and always has an abnormal EKG, or does it sound like somebody has just suddenly started having terrible chest pain? And that's where like that extra communication and you guys thinking through these things that can trip us up and saying, well, it doesn't sound like that, it doesn't sound like that, it doesn't sound like that. And then say, hey, I've got this guy. It doesn't sound like this, it doesn't sound like this. I think it's this is really helpful. It makes everybody feel more confident and feel like they know what they're going to get. And, it's just like when athletics, if you visualize what you're going to do, be it a jujitsu move or a tennis shot or whatever, then your performance is actually improved when it comes time to play. And I feel like for a cardiologist, proceduralist, and care teams, it's the same. So when we know more about it, we feel like we see what's coming in and then they actually show up and it looks like what we thought it was going to look like, everything goes smoother.
So a question that you kind of mentioned earlier about getting the name and the date of birth for these patients so you can kind of pull their history if they have something
Yeah.
to check. I mean, that's something that EMS can do. You can either enter it on your 12 lead when you send it in, or you can give that over the radio or over the phone. The radio is encrypted through our system right now that we have. We've checked into that. So that's good to give.
Yeah, because that's something we historically have never done and I always assumed was a HIPAA thing. But so many of these people, especially the older populations, and the frequent flyers are so chronic and have so many EKGs in our system that we can, and there's just so many people out there walking around with ST elevation all the time. And you're just like, man, every time this person comes in, we do this huge workup and then we realize that, no, that's just how they always look. And I'm always amazed, but they're out there. Yeah, question.
Any recent cases with like posterior MIs lately?
Not that I have reviewed. We haven't had a meeting in like a month, so but I don't recall any major ones. No, as far as like what it looks like or how the outcomes are and all that.
EMS misses it on the front side.
I don't think so. I don't think so because those are going to be abnormal enough EKG. I think the fact that you guys are sending EKGs, I mean, that is like a little minor miracle. I mean, you're old enough that you probably remember, like, we didn't have smartphones and like it's a minor miracle. Like to think that could be done at somebody laying on a floor in a house and like.
Yeah, I feel like I was halfway through my career before I saw the first 12 lead in the field.
Yeah, I mean, I didn't think that would ever. I remember when it first started happening, like, really, that's a thing? You can do that? So that just having that piece of information, unlike strokes and so many of these nebulous things that we have to deal with and everybody wants us to do a better job at, like STEMIs are, like, it's one of the few things where you look at a piece of paper, like, yeah, that's probably what's going on. And so just having that piece of paper in front of you that shows it is awesome.
Yeah, I've had the opportunity the last little bit to stop by a station and they've got a call on a chest pain. So they said, hey, come along. And so, of course, the old fireman in me says, sure, I'm going to go. So I ride along and I'll actually have my phone turned on. And when they send the 12 lead to St. Mark's, I can actually show them the 12 lead right then. As soon as they hit the button, it pops up on my phone.
That's awesome.
And so it's just amazing how fast it comes across. Okay, any questions online? If you do, just feel free to.
With the LVH, how common is that? Because it seems
Very.
like every other 12 lead we do
Very.
is LVH.
Yeah, it's extremely common. And most of the time, it's just going to be big voltage and maybe like a 0.5 mil of ST. And you're going to be like, oh, it almost looks like it's trying to be a left bundle or something. And those are the ones that really I don't think they trip us up that much. But like the one I showed you, like, there's a few of those out there. And where I came from in the Southeast, where we got tons of African Americans with 5 blood pressure medications, that are eating pork rinds and stuff. And it's like their blood pressures are through the roof. And I'd see EKGs like that all the time. You're like, oh, what do I do with this?
So with that, with the 25% of the
ST elevation compared to the RS is what you're looking for. So basically the biggest part of the spike in the QRS, and then you measure that against how much ST elevation there is. And if you got a huge QRS, even like 5 millimeters of ST elevation is not going to look like all that much. And you'll be like, oh, well, it's there, but man, that QRS is so big, it almost doesn't matter. You might have to turn your gain down to half on your, do they have adjustable gains on their 12 leads? Yeah.
Yeah.
And if so, you can just see the whole QRS, and then that should make it more clear. Because if it's really big, I mean, if it's 50% of the QRS that the ST is going up, that's, I mean, that's going to get your attention, but you're going to be like, wow, that doesn't look like most of them that I see.
We regularly see 12 leads where the QRS complexes are.
Touching. Yep. Yep. And then, yeah, just turn the gain down and see what it looks like. And then you can make some decisions.
Thank you.
Yeah. Yeah. That's a tough one, but it's out there. And
Okay.
I don't think our society's getting any healthier. So.
Any other questions from you guys in here? No? Yeah. Well, with that, I don't see any questions online, so we're good to go. Dr. Ellers, thank you so much for being here today.
Thanks for wasting a perfectly good hour of your life with me.
Oh, yeah, no waste. So we do have this recorded, so I'm going to send this recording out to the medical managers so they can actually get out to their crews and go that way. So appreciate everything, and thanks again. So everybody have a great day.
Appreciate it.
That's the first class I've had on against STEMI. So, flipping STEMI class.
Yeah. I think we're seeing a decrease in STEMIs coming in right now, and that's kind of been across the board. Yeah.
Well, I think that is.
I think our problem is with comparing everything to COVID. So I think we had a lot of increase in STEMI during COVID. And now we're seeing a decrease, but it's really more.
Back to soccer?
Yeah, we're going back to baseline.
They're back to normal.
Yeah. And we're seeing now, stroke like through the roof right now. Maybe it's because we're training on strokes.
Oh. Do you see a correlation?
I do. Well, you know how it is when you're in the fire station, you go train on something.
And it happens the next call.
Yeah, you have that call.
Yeah. You made it?
So, we need to train more on STEMIs, and then we'll have more STEMIs.
You can train more on town fire.
Yeah.
I remember doing a training with Reynolds at one of